Measures by Rajesh Sinha. So because time is pretty less, and yes, Rajesh, because he's going to talk about pre-operative, per-operative, and post-operative, because everybody has a different regimen. Nobody follows this. No, so Rajesh will tell us what he does.
Yeah.
Rajesh, we know, is the honorary treasurer of AIOS, and more than that, I think he's an excellent clinician. You see surgical videos, you learn every time. So very nice videos he shows, and he's primarily interested in cataracts, secondary IOLs, refractive surgery.
Thank you, sir, and a very good afternoon to all of you. I'll be a very nice presentation on how endophthalmitis should be treated and how it could be detected. But I'll be talking about what all we should do in order to prevent it. So I don't have any financial interest, and so there are various risk factors that are involved in causation of endophthalmitis, and risk factors can be preoperative factors related to the eye of the patient, lid of the patient, etc. Some intraoperative measures that we have taken, some infection can go through the instruments, some solution, etc. And of course postoperative as well. So as I said, there are certain preoperative factors, like if there's an infection in the lid, if in conjunctiva, and the patient has undergone any infection, any nidus is present, and the patient has undergone a surgery, then that is definitely a risk factor. High blood sugar, uncontrolled blood sugar, it further aggravates, because normally you do have some normal bacterial flora, etc. in the eye, which may be there, but it may not get very prominent. It may not become very dominating if the local immunity or the systemic immunity is not is proper. But because of high uncontrolled blood sugar, this happens, and then the growth of organism increases, and that flares up the infection actually. Then there are certain preoperative preventive measures that we should take, that whenever a patient has to undergo cataract surgery, a thorough evaluation of the lid and a nexa should be done. That is the area from where the infection goes the maximum. The coagulase negative staphylococcus is the organism, which is the most common organism, that is present as a commensal. So that is a big issue, and that can result in infection. Then of course regurgitation test is normally done everywhere and anywhere. That should be emphasized, that it should be done. Then no contact procedure should be done on the day of surgery. That is very essential, because the infection can pass on from any object. And then of course starting prophylactic antibiotic is something about which I will again discuss. Then other things have to be evaluated, blood sugar has to be controlled, and other systemic evaluation should be done. Now coming to preoperative antibiotics, the idea is to decrease the load of the microbes in the cul-de-sac. That is one, and that is basically as a prophylaxis. Now this prophylaxis, whether it should be given for a long period before the surgery and or not, that is a big question. Now earlier, a few years back, there was a recommendation that we should start the antibiotic 3 days before the surgery, and that is essential. That was the international recommendation, and that everyone was following. Now these days there's another concept that people feel that if you give too much of antibiotic, there's risk of resistance, and all those things are there. Whether we require any that much of prophylaxis, or maybe a single day prophylaxis is needed. A lot of debates are there, different opinions are there, but now most of the people feel that 1 day of preoperative antibiotic is appropriate, because that is basically for prophylaxis, and that is appropriate. Now, apart from obviously antibiotic, I'll be discussing other things as well. So which antibiotic to use? Well, one should use a broad spectrum antibiotic, and one should use a bactericidal antibiotic. One should never use a bacteristatic antibiotic, because that will cause further problems, resistance, and all those things. So fluoroquinolones are the ones which are very often used in taking care of this. Then of course other general measures should be taken. You should take consent of the patient, and high risk and everything. Pulse oximeter should be done. The sterilization of OT should be maintained. That is very important. Then sterilization of instruments, plus sterilization of instruments in between procedure, that is again a very important thing. And what you should do, that you should document. These days, now there's so much of issue of court cases and litigations and all that. So you should have a proper documentation and a photographic documentation of everything, that sterilization was done, this was the color change of the indicator, and all those things should be done. So that is documentation is the key. If you have not documented, that shows you have not done. That is what is implied in a court of law or by anyone. So documentation is the key. OT layout should be as per the guidelines. I will not go into details of it. Sterilization should be done, proper mopping and all the methods should be followed in order to sterilize the OT. The instrument should be sterilized, the high-speed sterilizer, you can have plasma, you can have autoclave, all these, in order to sterilize the instruments in between cases. That is most important. Because we always operate multiple cases, and in between cases the issue comes, and then there can be infection can go on and on in multiple cases. As far as surgeon scrubbing is concerned, one should definitely scrub it very properly. One should follow proper rules as far as scrubbing is concerned. At least 3 scrubs with a solution equivalent to 4% chlorhexidine for at least 3 to 5 minutes after under the tested running water. And ideally speaking, a clock should be placed in the washing area to actually see that yes, you are washing it properly for a proper period of time. And after washing, the hands should be above the waist. The hand should always be elevated. It shouldn't be down, otherwise the solution, the fluid will trickle towards your hand, and that is not acceptable. So it should drain away from the hand. So that's why the hand should be kept up. That is important. Then 10% povidone iodine should be used for surface painting and cleaning, and 5% povidone iodine solution should be used in the cul-de-sac and kept for 1 minute. Now, there was one study in BJO wherein they said that a double contact of 5% povidone iodine between for a gap of 10 minutes. Like you do it once, wash it, and then again after 10 minutes you take the patient to OR, and then again put 5% povidone iodine and keep it for 1 minute, and then remove it and then start the surgery. So double contact reduces the organism further, but I feel still most of us and most of the guidelines, they don't emphasize too much on that. That is just one study that I have come across. But most of the basic idea is that 1 minute of povidone iodine 5% in the cul-de-sac is the key to prevent infection. That is the most important thing. You can leave aside all the pre-operative antibiotics, etc. And of course, meticulous lid draping, because lashes and etc. all should be properly draped so that it should come under the drape. Then of course the irrigating solution, etc. should all, whenever you are using it, there should be there are certain specific guidelines. Like for irrigating solution, you use transparent flexible bag or in bottle container, and you should always check the bottle for any suspended particle in it, or whether there is any leak or not. So that is very, very, very important. And you should always record the batch. When you are using one day, you are using one batch of fluid, you should always take a photographic picture. You should always keep a record, always keep a solution. Ideally speaking, you should keep a solution of that, sent for culture as well. But you may not do it every day, but you should always retain the documentation related to the batch of the solution. That is most important. And viscoelastic should be used in one patient, and it should be finished. It should not be reused. And of course, as I said, the batch numbers have to be checked repeatedly of everything, like for the viscoelastic, for solution, for everything. And a lot of buzz is going on regarding intracameral antibiotics, and there are studies which have shown that intracameral antibiotics, cefuroxime was used in, it was reported in ESRS 2007, long back, that intracameral ceftriaxone prevents endophthalmitis to a great extent, 5-fold reduction in endophthalmitis. Then people started using moxifloxacin, and moxifloxacin, unpreserved moxifloxacin is something that one should use, not the preserved moxifloxacin, and that can be used. And this is one study by from Arvind group by Dr. Harpriya et al., which have reported. We are also doing a multicentric study, and a huge number of patients have been already done. So in this study, they concluded that intracameral moxifloxacin causes a 3.5 times reduction in endophthalmitis rates with the use during the surgery. And that is why these days most of the people, majority, not all, but majority of the people are using intracameral antibiotic at the end of the study, at the end of the surgery. And this is one study which was related to guideline, like, what kind of surgery resulted in more chance of endophthalmitis. So people saw that, the clear corneal incisions had a slightly more chance rather than scleral tunnel incision. Then some IOL related also stuff was seen, that silicone oil had more adhesion of, it is a known thing that silicone attracts adhesion of all these molecules and all these microbes. So they reported that 3.13 times the risk of endophthalmitis was higher if silicone oil IOL was used. But these days we are not using silicone IOL, so that is absolutely, that doesn't carry much meaning. As far as post-operative treatment is concerned, we normally, most of the surgeons now are doing topical surgery under topical anesthesia. So we don't do patching. But what I advise is this, that patient, after doing it's a daycare procedure. So you do patching till the patient reaches home. And after that, he can remove the patch. So that will be an extra protection in order to prevent dust and dirt and infection going into the eye. And topical antibiotics we use for 10 to 14 days, and topical steroids for nearly 4 weeks. And we don't use systemic antibiotics, and that is also not recommended. In very, just for the sake of completion, it is always said that systemic antibiotic is used in high-risk cases, but the proportion of that high-risk case is very minimal. And the first week is essential. Why? The first 24 hours are essential, and then first week is essential as far as the follow-up is concerned. That's why we follow up on day 1 and day 7, and then after that 1 month. If nothing is there, on day 7 you can ask the patient to report if he has any symptom. Otherwise, he may not report as well, and the patient can come directly after 1 month. So the idea is that the patient should be educated regarding this thing, that the risk of infection and the risk of all these symptoms are more likely in the initial post-op period on up to day 1 or maybe up to day 7. So you just have to be a bit careful. As far as camp surgery is concerned, if you are doing camp surgeries, then there are certain recommendations based on our own AIOS guidelines that we should not do more than 25 eyes per surgeon per session of 4 hours. Now these days surgeons can do very fast surgery, but that doesn't mean that the surgery can take even lesser time, but the measures to prevent infection should take more time, so that the patient does not have any infection. And combined surgery should be avoided. Then topical surgery should be done, or high-risk surgery should be done only by experienced surgeon with due precautions. One-eyed patient should be avoided in mass surgeries. Unless he's a hypermature cataract, then you have to take all the precautions, use your best surgeon, use your best equipments, etc. And there should be dedicated OT and no makeshift OT. And as I said earlier, that the commonly isolated microbes are the coagulase negative staphylococcus, which is already there as a commensal in the cul-de-sac. And I won't go into the post-op acute endophthalmitis, very nicely presented by Dr. Avninder. So what I would like to conclude here is that prevention is definitely much better than cure, about which even the best of retina surgeons, we have Avninder here, we have Dr. Nirmal here, and others as well, they will all agree that preventing endophthalmitis is a better tactic rather than thinking about treating it. Obviously, we have to treat once it is there. And most of the infections are due to contaminants or due to commensals. They are present in the eye, or they are contaminants through the solution or through the instruments, etc. So these things should be prevented. As far as lid margin and cul-de-sac is concerned, betadine, povidone iodine should be used to take care of that. And for the solution and instruments, you have to maintain proper sterilization. Look at the solution, as I said, look for suspended particle, maintain a record of the batch. So all these measures should be taken, and as I said earlier also, documentation of all the measures taken should be there so as to prove that you have done it, because if not documented, that means it's not done. So that is the most important point as far as your safety and of course patient safety is concerned. Thank you very much.
Thank you, Dr. Rajesh. That was the most comprehensive lecture on pre-operative and post-operative protection.
Thank you, sir.
Thank you so much for it. So maybe you can take some questions from the audience. Yes.
I've got two questions. The first one is, the preloaded ions, do they have any benefit for preventing like endocrine? Because you mentioned the method of insertion as no role. The other one is
That was one study actually. Method of insertion had no role, but
because
yeah.
while counseling patient, we tell as an extra advantage to the patient. So is it
See, there's no study comparing preloaded versus not, loading. But the thing is that logically, preloaded ones should have less chance of contamination, because when you are loading, then also you are using multiple instruments. There is a key, my teachers at RP Center, they always said that the key is that use minimal instrumentation. So minimal instrumentation will have minimal chance of transferring infection. So the preloaded ones are already loaded. They are there in the cartridge, they are there, and they have been sterilized. So the risk of contamination during loading is not there. So theoretically, definite advantage is there, but there's no study, comparative study, based on which I can say that yes, it shows that it is there. But logically appears to be yes.
The exposure of the IOL surface is restricted in preloaded. And second, you are not exposing the lens to the surgical environment.
Yeah.
Because very often when we handle too many instruments, they can be cross-contaminated already. And if you use the same instrument, so that we have seen during loading the IOL, some cotton fibers or certain materials stuck onto the lens, viscoelastic. So this can act as an IDUS. So we are preventing in a way, both theoretical as well as reducing the surface contamination.
okay. And sir, do we have to use glass bottles autoclaved or the BSS commercially available? Which one should we follow?
See, actually it is said that the best solution is the BSS Plus in the plastic
No, but
container.
in the end of point of
And,
view, because
yeah.
in between, like I remember, I discontinued one of the company's BSS because I heard that like it is risky and the batch came out.
Actually, it is
No,
with
this
everything.
is a big
certain
debate.
batches.
Okay, but from the pharma point of view,
Yeah,
so you
but
concluded
it's,
your question?
Being safe, like autoclaving yourself, the glass bottles should have.
Okay, so you are opening up a Pandora's box, right? So we are suspecting the entire pharmacological supply chain system, right? So we have to believe that in PVC, there's no added advantage of autoclaving. And same way in glass, there have been a lot of pharmacological industry-based studies that the glass bottles doesn't offer any added advantage. In fact, there is a risk of contamination when you are autoclaving because the cap, mostly it is a polyvinyl thing.
Yeah.
So by heat method, it's expanding, and if there are micro openings, there is an added risk of contamination. Second thing, you are, by autoclaving, increasing the temperature, you are altering the pH of the solution. So this, in fact, can induce a TAS. So when you alter the pH, so it is neutral pH, the solution. When you alter, RL or BSS are thermolabile. It can affect the composition. So the bicarbonate part can evaporate. So you are altering the pharmacological composition of compound lactate, which we are not supposed to do. So generally, the pharmacological expert doesn't advise added autoclave in your system unless you suspect something and then you want to be doubly sure. So that only gives added safety and maybe a good night's sleep. But I don't think from the endophthalmitis point of view, it adds anything.
So if she suspects, she should not use it. Why autoclave and still use it?
Exactly.
Throw it.
Throw it. So trust your pharmacological, and main thing, have an eye on the supply chain management and where your people store the PVC or glass bottles.
So sometimes some small fiber gets into the anterior chamber post-op. Next day we see it. Should we go after it vigorously or keep quiet and pray?
Keep quiet. So many of these all sterile fibers.
Periodically see the patient
Yeah.
till at least 1.5 months.
Right.
Nothing happens after 1.5 months, it will not work.
Rajesh, I have a question for you.
Yeah.
Since you are doing a multicentric study,
Yeah.
with rampant use of moxifloxacin intracamerally, what is the risk of antibiotic resistance to moxi? Because that's the only drug we have now, a potent drug. The next antibiotic is not in the, it's still in the pipeline, does not come to the clinical picture.
True.
Are we overdoing ourselves by doing this?
Yeah, actually, I always felt that we are overdoing it, and but the trend now, because of the litigation factor, I mean, I always felt, because for only last few years I have started using intracameral antibiotics, moxi, but otherwise, I mean, till 3 years before I was not using it, and many people were using it. So I always felt that we are overdoing it because the risk of resistance will be high, and I agree with you. I mean,
Because it's a huge numbers.
True,
We are doing
true.
surgery in millions,
Yeah,
and
yeah.
this exposure
Yeah.
can lead to resistant strains.
absolutely, that is very true. I completely agree with you. I mean, that is why initially, pre-operative antibiotics were, when it started with a longer period. Then people told that don't use it too long, otherwise there will be resistance. Similarly, for so much rampant use of intracameral moxifloxacin, the risk of resistance, development of resistance is really high. That is very true. That
So
cannot
what would be
denied.
the alternative in case moxi develops resistance?
Maybe like people who have used cefurexime, that is not very commonly used, at least in ophthalmology. Maybe systemically people have used, so that may be one option, and that is safe as far as intracameral use is concerned. So that may be one option.
Because most of the time, vancomycin we are limiting because that was the only drug available
Only,
for
yeah.
intravitreal usage.
Intravitreal
Same way,
as
should
well
we
as-
initiate some
yeah.
proper guidelines to limit the use of intracameral drugs only for high-risk patients?
I completely agree with you. The only thing is that when we do all these multicentric trials, what happens that we do thousands and thousands of cases, and there can be some confounding factors also, which might have caused, and there's the number of endophthalmitis is not high, but still, if there are 2-3 in one group, that confounds, or there may be some other factor as well. Maybe betadine was not used properly. So many factors are there. I completely agree that the risk of resistance is high if we use intracameral moxifloxacin so much. And at this point of time, moxi is used systemically as well, and that is also one reason why the risk of resistance is higher with moxifloxacin. And what vancomycin, what you are telling, the same we follow when we treat corneal ulcer patients also, because we don't use vanco routinely because we keep it as a reserve drug for those, Dr.